Really excited to see what we got here. Like I said, we may have a few folks join us online, and we may have a couple more folks pop in the next 2 minutes. So if you guys are ready, go ahead and take it away.
I'll just do a short introduction.
Yeah, absolutely.
So,
sure.
I love being in this college because Darren found out that I was doing a workshop, pre-conference workshop, on this topic of the International Classification of Functioning, Disability, and Health. And he said, "Oh, can you do something for Tuesday topics on that?" And or somebody asked me that, and then we got a very good question to make it interprofessional. I'm coming from it as a scholar in the area of disability and functioning and how do we measure things. And I've been working in that area for a long time, been working with we call the ICF for a very long time. And I knew that in physical therapy, the ICF is part of their standard practice guide. So I knew anyone over there probably knows a lot more than I do on the ICF, and that definitely will make it it's professional. So we'll start with Kate Mitchell we've done that here.
So nice to have you guys. And who's online?
Right now we have Justine Sefik, who is one of our new postdocs.
Oh, okay. Welcome, Justine. So my name is Kate Mitchell, and I'm a physical therapist and a faculty member in the Department of Physical Therapy and Rehab Sciences. And my area of practice is adult rehabilitation. So we work with our students to apply the ICF model to all diagnoses when they think about their doing an evaluation when they first meet their client or their patient. And it applies very nicely for your more complex patients. And so it is an easy model for me to be thinking about. And it is nice in the years this is my 17th year of teaching, and I've really seen our profession start to use the language and get away from more disablement and thinking more about activity and participation, and really you thinking about the big pictures of the contextual factors. So we'll go ahead and start with the idea. So as Christine said, you guys are all familiar with the ICF model? No? Okay. So it does stand for International Classification of Function, Disability, and Health. And with, it's nice that we abbreviated ICF so that emphasis is on function.
Right, exactly.
And so it would be kind of neat if it also had the H though, because I think that health piece, I know from a PT perspective, sometimes we're very over-focused on function. So it is a conceptual tool. It was created by the World Health Organization, and it was first adopted, what year?
2001.
2001.
It was passed by the World Health Assembly in 2001.
So it was created to be a common language to be used internationally, so that when we were talking about health and healthcare in individual sense, the global sense, we would really be using similar terminology. And it is, as our slide says, it is a model that is used, frequently used in rehabilitation sciences, so that certainly covers PT, occupational therapy, speech pathology.
Do you want to advance the slides?
Oh, okay, sorry.
I'm sorry, I'm not doing a good job. Okay.
Yes, thank you.
So,
And also in social work, and it can be applied to any a individual at any part of the continuum of care. So it is certainly applicable if your person is in the emergency department, all the way to outpatient therapy services, to someone in the home. And when you look at it for children, you're certainly looking at you're looking at the child, but then also the context of their family. So, child's family-centered care. And so if you go ahead, what we are seeing, a limitation though, that it is not fully integrated in medicine, nursing, and public health. And clinically, I would say that that's true for us. If I were to talk to a physician, call a physician up, and I wanted to say that I was concerned about my clients' participation, which is how they interact with their community. If I use the word participation, that physician would probably wonder what are they participating in? They would think about that verb in a very traditional sense. So I do believe that we need to work harder to try to integrate it. And knowing when I look at nursing documentation in the hospitals that I work in, you're not seeing the language used there either. And then, as Christine said, public health is starting to consider it.
Right, and I'm looking at it, I'm gonna talk a little bit more
Yeah,
about it.
yeah. So, all right, take the next slide. So here is an overview of the model, and you guys have, if you grab, so you have the handouts, which are nice and big for you guys. And so what we start out with, if we consider an individual, the first thing we want to think about is we want to think about the health condition that has brought them for us to meet them, or what is the primary concern. And from there, you just have that as that broad part of the umbrella. And then what you're going to do is under the next level, you're going to look at when we look at 3 subcategories that are primarily related to the health condition and the individual. So body structure function, that term refers to what structures and how they function and are impacted. So let's say if we take somebody with let's say we'll take a simple orthopedic condition. Let's say we have somebody that fractures their hand. Okay, so they fracture their hand and they are a mechanic. So right now, they're a mechanic, and so what is limited by their hand fracture, it's going to be the active movement of their left hand. But what do they have available to them? Something that's a positive. They have availability of their right hand. Their mind isn't impacted, so that's going to be a positive factor that they can utilize. So we can talk about how can they compensate, how can they make sure that they take good care of their hand so that they can recover as soon as possible. Then you go down here and you say, well, what is the activity? The activity I usually define activity as things that we do that involve in taking care of ourselves to get through our day. In rehab, we often use the term ADL, activities of daily living, but it can be a little bit broader than that, because an ADL is typically your ability to dress, bathe, get out of bed, walk, but it could also involve, meal prep, things like that. It could also involve, doing your checkbook, paying your bills. Participation is defined as your role outside of yourself. So that is any type of interaction that you do with people in your community. And again, community can be defined very broadly. It can be people socially outside, but it also can be in your family unit. So if this man is a father, he's also a brother, maybe he is a minister at his church, or he volunteers with the local football team. So participation is anything that they do outside of taking care of themselves. And that is really important to be thinking about, because sometimes physical therapists can be just focused on the hand. So I'm focused on the hand and I'm focused on getting all these impairments better. But what do I want to think about is what are the other things this person needs to get back to besides just doing their job? And then if you look at everything's interdependent, and the other big pieces that why this model is really useful for the big picture in healthcare is thinking about environmental factors and personal factors. And these can be, I would say, either attributes or barriers, things that can make their ability to function right now with this condition easier or harder. So let's say for the environmental factors are going to be the type of home they live in, do they feel safe in their neighborhood, how do they get around, do they take public transportation, do they live in a 2-story home, a 1-story home, who lives with them, environment, are they there by themselves? And I don't know if you think about this, Christine, but sometimes I feel like sometimes the personal factors and the environmental factors can kind of be a little bit fluid.
They can,
Right.
And we have less, those of us doing survey and data research, we have less research on personal factors. And these are the things that the occupational therapists, health educators are really focused on, things like your willingness to change, or your adaptability, and it may depend on that individual person.
Right.
It also may be some researchers, and I'm not sure how appropriate it is, but it is certainly a real personal factor, is that we have literature that demonstrates the role that poverty plays in accessing services or getting outside of your home. And those are things that person may or may not have control over, but we should know about them as those barriers or facilitators, right? So, so that tends to focus on the individual, but it is, I agree that it can
It
overlap.
can overlap with the environment, right? So.
Yeah, and sometimes, environment also is around the individual, and it could be that immediate space, but it also could be the policy. The policies so in some places, if you're around the world, when you have a disability or you have some kind of marker on your ID or something, then all the transportation is free.
Right.
But we don't have that, but that will matter. That will matter to that individual in terms of you're telling them that they need to move and get outside their home. But if finances are a factor, that's an environmental. So usually with the environment, we tend to focus on the things that are around the individual that they don't have control over. But we also want to make sure we recognize the barriers as well as the facilitating.
So is that like the social determinants of health would fall in that?
A lot of them would, yes, and that's a public health
Right.
terminology, yes, and that's a very important
That's an
point.
excellent point, right. So, so that could be the environment, or sometimes let's say their health insurance, right? So I often think
That was your
about,
question, good.
right, health insurance, I often think of it as a personal factor,
Yeah.
right? Or let's say that this individual doesn't have a second person to help with the income in the house. And so right now they're out of work, they have health insurance, but they don't have any insurance to bring in dollars, right? They don't have an Aflac. So, but if they had a big savings account, or if they had a spouse that could help provide, that would be less of a factor for them.
Right, and those personal factors also interact with the individual, because we have individuals in the home that could have a lot of negative ideas about disability, and they may have kind of given up on that person, which is not, and that individual could believe that and think that, and they don't have it, they may not have enough interaction with the healthcare system to recognize
So
that they have the ability.
it's not just internal, external, within your control, outside of your control.
Not really.
No, right.
So
Yeah,
it's very difficult to distinguish those.
But at the same time, personal factors, like I said, we have less literature on that, and I think that the easiest way would be to be about easiest.
It's just that individual.
that individual, like their personal attitudes and their
conceptual.
perspectives.
A lot of times they talk about like their motivation, their willingness for change.
And how do they see either recovery or
Literacy.
or how do they see disability? Like, so for example, if they have taken this on and they have an injury, which is how physical therapists might relate to this person, but if they have an injury, it's really important for them to understand what resources are available to them, but if they don't have that, then they may not be as motivated or whatever. But if they are talking about lifelong disability, it's a whole different it's a whole different picture, and they may actually have very strong motivation for finding the resources, and they are maybe actually even very good advocates for.
Right. And one of the things I think about too with environmental factors, so sometimes like the example I use a lot of times with my students when I talk about clients with spinal cord injury. So you have an able-bodied person who's walking around, as easily as you and I through their community, and then they have a spinal cord injury, and now they're a full-time wheelchair user. And in a certain environment, they're completely independent, right? But then if they happen to live prior to this, they happen to live in an elevator access apartment in Philadelphia, they may be able to eventually use public transportation and they can get in and out of their home. But if they live in a row home in North Philly, their environment is a huge barrier for them to return back to their community. So then we say, okay, so that can we move them? Can we adapt it? Could we put a ramp in so that they could get into their home in the backside? And then if we put the ramp in, we've negated that barrier, and now they are independent in their community. So one of the things that this looks at is what's modifiable and what's not. So we can't change the fact that this individual has a complete spinal cord injury and is not going to be able to walk. But can we change the environment where they spend their time so that they can be independent? Depending on the job they did before, if they did a job with their hands and their mind, they can return to their job. If they were a laborer that required to go up flights and flights of steps or stand for long periods of time, they may not be able to do their job. So we would want to go back and say, what are the positives that they have here? and that can enable them to be independent, and what can we change or help them work towards to be as independent as possible. So the whole focus on, and a lot of times in pediatrics, physical therapists like to refer to this as an enablement model. And in fact, they will often not write any negatives. So instead of saying, the person has paralysis of their legs, they will say they have full use of their arms and they're independent in propelling their wheelchair. So they just kind of always think of it from that perspective and think about how can we capitalize on the resources. All right, so any questions on those terms? But what you guys are thinking about, like that fluid and which box do they fit in with personal and environmental, it would be interesting to talk with Christine more about that, because with my students, what I do is I say, as long as you're thinking about all these things, I'm not so focused what box to go in, as long as we're remembering to think about the person and think about their environment. So what I gave you guys here is a classic case example that I've used with my students, and I thought we could go through this and you guys could see how we would apply it. So this is a condition, so those of you, if you're not familiar with multiple sclerosis, it is a chronic neuromuscular condition that involves demyelination and inflammation of your spinal cord and your brain, and it can result in a variety of clinical presentations. And it's a chronic condition. There's a lot of medications that can help, but once you have it, you oftentimes have what we call a relapse of the disease. So you may have another onset of it, sort of like a flare-up of the disease. And so, and it is common. It's typically most common in females, diagnosed initially between the ages of 20 and 50. So this is a classic kind of real-life presentation. It often is first diagnosed after a trauma, which birth certainly is a trauma. So this woman had she was first diagnosed 5 years ago, and now she's back in the hospital after having her third exacerbation. So it's important to know how often she's had this condition. So that's our basic history. And so even from this, we can learn some things. We can automatically identify the health condition. So what's the health condition that brought her to us? MS, exactly, okay? So then if we flip the slide, Christine.
I'm sorry.
That's okay. That's okay. So then this is just a general thing, and out of this, we can certainly start to pick out some of her body structure function challenges, and then also her activity and participation. So she has weakness in her legs, but she has good arm strength. She has good sensation. She needs help getting up. Supine to sit is sitting on the edge of the bed. She needs help getting out of bed. She needs help to stand, and she currently cannot walk. Important to note, she was walking before the Rita came. She's got some changes in her vision. She is alert and oriented ×3. She's a little bit labile, meaning that she might be a little bit tearful, and she has some decreased insight. So she really probably thinks she can do more than she can right now, because she's just that strong-willed mama. So if we flip to the next one, this is how I would apply the model to her case. The condition that brought her to us is MS. Some samples of body structure function would be that she has weak legs but strong arms. We could certainly add a lot of other things, like vision would be important to note, of course. She needs help with her ADLs and her ambulation. She currently can't stand to sing at church or volunteer at school, and these are things that I ask my students to kind of just imagine, what would you do? So these would be questions you would want to make sure you ask.
Right.
And a lot of times physical therapists, when we are very focused on this initial part, these impairments and the activities, we may forget to ask about that. And it's going to be important to document and keep her in care until she can do all those things that are part of her community. What are some environmental factors? It's nice that she's in a one-story home, but it's a very busy home. Another plus is that she has family around. She's not alone. She's not isolated. And then the last one is, I did all good positive factors for her. She's motivated, she has good health insurance, and she has a strong religious faith. But we could also say, maybe we could say that, she is battling depression, or she's recently separated from her husband, or she's recently lost her health insurance, things that might be more of a negative factor. You're trying to balance those two. So then that's a very classic PT application piece, and then Christine's going to take it a little bit broader for us.
So, and when I'm what's interesting is that the clinical folks have been using this in so many different places, and it really is a framework. It wasn't designed to be an assessment tool. It wasn't
Right.
designed to be a measurer of any way. But what it does is it provides a framework that's much broader. And so the concept of disability is more of a concept, and what we're breaking it down into is functioning, and how do we function in different parts of our lives. And so in that way, it can be used in other contexts. And so we know that ICF is used for a variety of objectives, mostly in Europe and Asia and Africa. In research, policy, education, clinical practice, and rehab. So it is there. I'll just say, when ICF was passed, 2001, I was part of a team that we launched it in New York. Not me, I was very small part of it. But there was, but we also launched it in Italy, and Italy took on the ICF and integrated it into their policy. They sent there's a little book, and now it's all online, but it was a little book at that time, and they distributed it to all their hospital directors, and they were integrating it completely into their health system. And so that's what we mean by
Yeah, it was
integration.
so different than here in the US,
It was
right?
just, they just really adopted it. And it is true that WHO is in Europe, but at the same time, there's also, it's also a place where there has been a history of comparing information and looking across different countries, and that's not always the same in the US. And sometimes adopted in public health curricula. We have a textbook on disability in public health. A few years ago, it was published. The ICF is part of it. There are other models included, so it's not a framework that's part of all master public health programs, but it is there. In medicine, it's most often used in the rehabilitation settings because, of course, the physician is working with the rehabilitation clinicians. But it's also used in oncology and other areas where people are living with a long time, the chronic condition. They're trying to participate in their activities, participate in the community as well as maintain their activities like work and other things. And then there are very many influential publications, such as the World Report on Disability, are all based on the ICF. Although when I talk to people in the World Health Organization and the World Report on Aging, it looks like it was just thrown in there, and it's not really clear how it's being used. I'm just letting you know. So some of us are, it doesn't mean that it's integrated in every single fabric of everything. So, okay. And then the advantages are really, what it's doing is we're coming out of, part of the reason why there are several advantages is because it was the result of many, many years of advocacy on the part of international disability organizations to get rid of the bias in the framing of the words associated with the old models, which include things like impairment and handicap.
Handicap, yeah,
And
that was the NAGI model.
For a long time, the word handicap
that
was fought, viciously. And so the end result is this model that does have a neutral language. That's good. And then, but also it was done at the world level, and so people internationally, and so there was people from all over the world were involved in the development of ICF, and so many think it is universal across different clinical fields, in policy, in education, and research, as well as across different countries. And then where we know it is being applied is at the individual level, because we know the clinical training involves ICF. And then it is not disease specific, but it allows us to introduce disease. This is also an area of interest for the disability rights advocates because the focus tends to be on disease, and that makes sense for clinical professions. At the same time, we know that there are other pathologies that happen in our lives that are disease, injury, over time. We have osteoarthritis comes to mind as something that develops over time.
And so what do you do with that, right?
So we just call that a pathology. And so the ICF allows us to use whatever language makes sense for that health condition. And that's why health condition is the most general way.
Sometimes it's not straightforward, right?
Right. And the other, I'll just say, and this is for, I know, Sherwin studies disability, and for disability rights advocates, and as you know, if you are a faculty member or if you've been introduced to accommodations requests, the notion of what is my disease, or why do I have this limitation, or why am I asking for this accommodation, is really not the business of other people, except for I need accommodation in XYZ so that I can do my job as a student and take this test. I mean, and what my clinical definition of my situation is another matter. And so you'll see lifelong advocates or in disability not talk about their disease or their health condition. That's a very big, and I know the clinicians know that.
Yeah, and it's interesting because sometimes you find yourself as this curious clinician wanting to kind of know, right?
Yeah.
But it's just, you have to remind yourself that it doesn't really matter why they're using that wheelchair. They're here to talk about ramps, and right.
Yeah.
So, yeah.
No, I
But
think
it
we've all
is,
kind
it's a tendency, right? And that's one of the things that I think you have to sort of, just shut that like curiosity side down and say, yeah, this is so cool. It doesn't really matter. These are all people that need to use this ramp. Who cares why they need to use it? They need to use it. Yeah.
Right. I think that's why, another reason why the ICF sparks these conversations. And then it is comprehensive because in previous models, the ICIDH was a previous model of International Classification of Impairments, Disabilities, and Handicaps. That was one directional, and there were no environmental or personal factors recognized. It was all about the body. And so this one is more comprehensive, recognizing all the things we just talked about outside of the individual. And it does, but it's comprehensive in that it does work for clinical practice because it is a model that includes, or a conceptual idea that includes the body system and function as well as activities and participation. And so it's not like leaving out the role of the body. And then it does provide a framework for classification and measurement. And that is one of the main points I want to make, is that it is a framework. And so it's not, there are several codes and definitions that are included in this, and it's thousands of pages long. I think it's very long, but now you can just access it and you don't really see how you can just access it on the computer. But the advantage of a classification that is not an assessment tool, is not one that includes measurement, allows for more people to use it, and it provides a framework where we can use language like activities of participation and be more clear. And for those of us who are interested in cross-national comparisons, we can work towards having the same language, and yet it is not binding us too narrowly. And then the other part of that is it has the flexibility. I think you alluded to that. It also has that flexibility built in so that if you know that there is this thing called environmental factors, and you know those tendencies, you know the literature about individuals with this these other factors going on in their lives, then you have a place to ask more questions and you can learn about it. And that, I'll come back to that and talk about public health. I want us to make sure we're going to our have time for your activity. Okay. This is hands-on. So it's only one more slide.
So I got an idea and I will start working on that.
Okay, so I'm coming to you from the American Public Health Association this week, and I did learn a little bit, but I've also been talking about, or I've been learning about ICF in public health for a long time. It's just that, as I said, in the US, it has not been adopted as much as a framework or a tool in research. But we have the potential to, and it is being done in other places. And so I just want to share that with you so that you know that it's very unique that a model or a framework like the ICF, which includes the body functions, allows clinicians to work on an individual basis, one-on-one with a patient, and that's where also our exercise is about that too. But at the same time, it's very helpful for those of us who are looking at population health, because we care about populations, and they could be subpopulations, populations based on social determinants, based on race and gender and other measures, but we are concerned about that population, and so I'm just giving a few examples of how that can be used. And so when we learn about our different populations, we do surveys or do research, we know more about them, and then we can kind of help define the populations. So one example is that a colleague of mine, he used illustrations to describe different kinds of functioning of seniors living in residential facilities, in his case in Japan. And he developed this, it's called an illustration library. It's many, many pictures. And what he was doing is he was using that as a tool for the caregivers, the formal caregivers working in that facility. For them to use many, many codes, it's not really helpful, right? But if they have a picture, I know that this person needs help to get out of the bed, or I know this person definitely needs to help going to the restroom, or this. So there are all these very helpful illustrations that he could use very quickly in training, but also kind of test them on it, and then they have a language to use as well. And I think he had some, when the caregivers were talking to each other, they had some shortcut words that they could use to help. But it was all based on the ICF. And so what he has now is a set of illustrations that he's kind of narrowed down for his population. And now he can better understand them, he can do research on them and their progression or their challenges, and it really has translated into population health. It's very exciting. And then another thing I was involved in was that we had the ICF framework, and the idea, as we said earlier, was to have a common language across different countries and across different places, so that we could talk about disability and functioning in the same way, because we weren't doing that before. And so one of the outcomes of the ICF was a group of researchers and demographers and policymakers who are called the Washington Group, because they had a meeting in Washington. It was their first place that they met, in Washington, D.C. And what they did, they wanted to come up with a set of questions that were fairly short, so that countries all over the world could use one set of questions that address disability and functioning across their population, and then they could actually compare data. And so there is a long version and a short version, and then and it's really important for all countries, rich countries as well as developing countries, because most wealthy countries have an annual health survey. And some of us worked strongly to show that disability and functioning, you should have that annually covered as well. We still don't have it in our census, on all of our censuses in the US, but we do have the American Community Survey. But in low resource countries, especially those throughout Africa and some parts of Asia, cannot just have multiple surveys every year, right? That costs a lot of money. For censuses, they can't just add a whole bunch of survey questions to their census and think we're going to cover. So we have now this short set of questions that is a mechanism for countries across Africa. One of our speakers actually was doing that work across 4 or 5 different African countries that address functioning, ask the same questions to that different population, and now they have data that they can use across countries. It's very cool, and of course, eventually look across what does that mean? What do those answers to those questions mean for resource use, and how can we plan for that? And it's very, very exciting. And so that is definitely population research, population health research. So I'm just sharing that. And I haven't seen very many examples of it, but okay.
So do you want to get to the
Yes, the
thing?
case,
Can I
yeah.
drive?
You can. So you guys should have a copy.
It looks like this. It's Bob's story.
And then, so you wanted.
And then you have this
Yeah,
one,
so
everyone's
it's
the
that
other
one.
this. So this model, maybe
Yeah.
you can work on it in 2 and 2 if you want.
Yeah, you could.
And Justine, you can just do it individually. But what we're asking you to do is to take a few minutes to read Bob's story and then think about how we would fill in those boxes. So maybe you can work on it together or groups of 2 or individually.
Justine, I know you're joining us by phone. Could I email this to you?
Sure, that'd be great. This way I could see the bottom of the sheet.
Yep, I'll send it to you in
Yeah.
a second.
Okay, thanks.
Thanks for being patient, Justine.
Yeah, no worries. Thank you.
I'm glad you're let me know when you're. Justine, you have a background in a clinical field, don't you?
Yes, I'm a nurse.
That's what I thought. Okay, nursing. So I hope I would love to hear some feedback later after we've had a chance to talk.
Sure.
So he's done with that. Oh, yeah. So it's about a few years ago. So, but what's still bothering him is that
All right. So what? So what is his health condition? Mental deterioration.
Right.
All right, Justine, you should have it in just a moment.
I think so.
I think it is, because
the ongoing
Got
issues.
it.
Right, yeah, and then, yeah, so this is some of those things, right, so he's kind of got 2 things going on. But
Yeah.
because
Right.
of that, he broke his hip, but right, and this is,
Right.
Yeah.
Oh, so you put the
or
mental
did
condition, or you put the
he have
body?
mental deterioration after he broke his hip?
well, he's a partner.
I think he had the mental deterioration.
Balance, fell over, so
Well, I think those are both.
I think he's got dual, and I think we'd be fine to
Right.
both of them.
I think those are both the health conditions. The body structure and function is what are the consequences of the
Right.
broken.
Yeah, I agree
So
with
he
you.
uses a walker,
I think
Yeah, so he can walk with a walker,
right,
environmental, I think that's activity,
but he has balance issues.
something
Right.
maybe like.
okay, would you put that as,
One of his like hobbies or something.
Yeah, to me, that's still body structure and function.
what about the mental, how could you?
Well, let's see how that, should we see how that plays
later.
out, right?
The
Okay.
other thing he likes to do.
Because that feeds into
Go out
the
with his friends.
Okay, so what should we put for activity?
So it's hard for him, he's completely missing when it comes to the housekeeping and shopping.
Right. So his activity is, you know, what he does do are the model trades and the.
Would that be participation?
The things that he's still able to do.
So this is like in his home, this is outside,
Oh,
walking
oh,
together,
okay.
so walking in his house,
Yeah.
right?
Oh, you could write that,
Okay, and then the fact that he goes out to see a friend, he's limited there because it says he can get out to see it, but he has trouble getting back. So one of the things he wants to do is, you know, socialize with his friends.
So that's
The question is, where does, like the trains, is that participation or is that
That's
activity?
activity, I think.
So model trains, that's inside his house. Yeah. So again,
You don't have to.
structurally, it really is. That's not something that he does to take care of himself. So it technically is an aspect of his participation. That's what he does for leisure.
Right, okay.
Yep. This has to do with like, can he stand long enough?
Right, his functionality.
Functionality.
Right.
Yeah, exactly.
Yeah.
So it has to do with like taking care of yourself.
So
Right.
participation, being with friends.
Right.
Model trains. He's also a partner, right?
Right.
So he's just, partner or spouse.
I see.
So walks with a walker.
Right, he can no longer do his job.
Right.
Which was as a trained. Train driver.
Yeah, right. It looks like, was he probably retired from that?
Yeah. Okay, so for environmental factors then, okay, so he can walk in the house, but the stairs are a
Yes,
challenge.
exactly. Right.
Where would his sense of time, that fits into the mental?
Yeah, so that would go under body structure
Yeah.
function here. That would be like a cognitive, it's got cognitive decline.
Okay.
I think but she, she's helping.
She's helping
wife. Right.
Alright, so environmental factors, he can walk in the house, the stairs are a challenge. The pub is a bit too far away.
Yeah, exactly, right.
Okay, and then personal factors might be also the relationship with his wife, because she's getting taxed.
Yeah,
it's
it's right, yeah.
Overtaxed, no children,
Yes, exactly. So limited support, right? She's the only support.
few friends.
And this piece here, I think, is important too, right? That
Partner
he
is
feels like it-
overtaxed
yeah,
and it's asymmetric.
right, he's got decreased insight, right? That's probably part of this cognitive decline. Yeah, so this is kind of interesting too, because we're doing this about Bob, but we could almost do it about her.
Yes, right, exactly.
You know?
Yeah.
Like you could almost do a second one about
Also,
her,
yeah.
because she needs support. So like that's how
That's
like
right.
someone from
So
a
would
social.
you treat both then?
Well, I guess it depends on like who you are,
Or
right? If
your
you're
right,
a
what your
social
role
worker,
is,
right? If you're
yeah.
a geriatric
Yeah.
specialist, right? You would be coming in and looking at the family unit and
Right.
looking at it in two different ways.
Yeah.
Yeah. I always come in from my patient, but I'm
Which would be Bob.
right. But when Bob comes in and we do a lot, like if he was being seen in PT, he'd probably be seen at home now, so we could come to his house.
Yeah.
And as a physical therapist, you really are looking a lot at the caregivers. And we do, by extension, realize in order to improve the environment and overall make him more functional, we need to support her. So we're recommending maybe she needs respite, so we need to identify somebody to come
So
in. So
you
she
do recommend
do.
some kind of
we do
support
that,
for her.
right?
Okay.
That's
We
interesting.
do
Part of
that.
that.
Right.
So Maria is another personal factor, right?
Yes.
She's a
So
support.
that's a good person.
And I would say access to the internet is at least like, they have some resources,
Yes,
some
right.
Well, that's a good idea. Yeah, that's excellent.
like they kind of have some sort of plan,
Yeah,
even if
right.
they're asymmetric in their
Uh-huh.
approach.
Right.
They're being a bit proactive.
That's
Yeah.
good. This is a good,
You guys are good.
You are good. Yeah. Cool.
You wanna move on to the,
Yeah, and talk about it. Yeah, just ask you guys to talk after they finish. A good time, yeah. Good time.
Justine, do you have any questions?
Nope.
Okay.
Do you wanna be one of the reporters? Talk
Do
about
you
what think?
use this model?
I have not used this model. I primarily work with persons with dementia.
Okay.
But in terms of, I had worked in a nursing and rehabilitation center as a nurse, and Bob would have been somebody in our facility getting rehab and going home,
Right.
and certainly these are all the factors that we would be considering on discharge.
Right. Right. So I agree. I think there are some healthcare systems that are thinking about these things, are just not necessarily applying the common language.
Correct. Yeah.
Yeah. Right.
And also, over time, there have been what they call core sets or applied variations on the ISF with its codes and focusing on particular areas such as spinal cord injuries and children and youth and other areas. And so maybe we probably could learn a lot about dementia, especially if we incorporated what others have learned about dementia from all different clinical areas and incorporated it. We haven't, that has not been done yet, but I think that we're learning a lot more about it now. So but that's, you're right, they're not using the same language, but
I mean, people that work with dementia typically are very focused on like the caregiver.
oh, yes, because there's
client-centered care, and
right,
that's really
right,
where it's going, right?
So does, anyone want, Justine, would you like to comment on anything that you found, or, and then maybe we can, as she speaks, we can ask others if you found the same thing? Like say, for example, for the first box,
Can you put the model back up on the screen?
oh, that's good, yes, put the model on, that's
Yep.
right, that's good,
Not that
that's
one.
right.
No.
That one, right, exactly. So we may not know all of the health functions, we know some things, right? But we, what did you start with as you looked
Yeah,
at that?
I was writing down about Bob and his having problems with his balance and his broken hip and his decreased cognition.
Mm-hmm.
So those are all functioning, and the hip is certainly that's an injury, right?
Mhm.
Or something
Right,
that happened
that's
to him,
one of
so
his
that could
health
be-
conditions,
That's
yeah.
one of the health conditions that we know about, and then these others may be indicators of others that have not been identified, right, like dementia or whatever,
Mhm.
but we know the functioning is there. Functioning issues are there, for balance, maybe for perception of time.
Yes.
Anyone else on body structure functioning that you?
Well, I mean, he has a
Yeah.
diminished, energy.
Yeah,
Energy,
sure,
yes,
because he can't
decreased
make it
endurance, yeah, excellent.
Endurance, that's the word.
Endurance,
yeah, so-
Endurance is, that would be a functioning.
And
element, right? Yeah, what?
then there's like a higher order cognitive thing that's going on with the railroad, you know, that he's not, you know, especially because this is something that he obviously had done for a long time. And so then to lose that, and it's not clear how much of that is fine motor skills and, you know, control of that, or decision making. And the way it's written, it's more of a cognitive thing, but it's not.
It's not
Clear.
necessary.
No, exactly, right.
We don't have a diagnosis.
But, you know, like, let's say you read from the previous note, you're just coming in today, and you're like,
Right.
oh, so tell me about why doing the trains is hard, right? And then you would use that model, and then you would then maybe fill it in a little bit more. Yeah, exactly. Good.
And then activities, his ability or his activities for daily living or instrumental activities of taking care of himself. What did you guys find? Anyone else want to start?
Well, he can walk in the house, but he has trouble with the stairs.
He's using the walker.
He's using the walker.
Mm-hmm.
And also the distance, which is probably related to the endurance, right? That he can get to the pub, but
He can't get that.
Mm-hmm.
Yeah. So is the pub maybe
Downhill.
downhill
Yeah.
from the house?
Mm-hmm.
So
Right.
you go down.
Or is it that the beer adds to his cognitive?
Exactly.
Or just
Because he
some
said he
time.
does one beer, but who knows?
Right, exactly, or just the time of day, yeah, exactly, right, multiple factors. But you're right, that's what caused you to kind of explore it, right? Is it the environment, is it the body structure? Because if it's the environment, you know, we maybe can't change that, but can we improve his endurance, right?
Right.
Right.
Yeah, yeah, that's great. And how about the participation piece?
That's his trains.
Mm-hmm.
But he doesn't really have the trains anymore, because he can't do it, which is a problem.
Right, so
Which is
he's
a problem.
lost, right, there you go, so there's a loss
Lost
of
his
one of
trains.
his social
Right.
joys, yeah,
Right.
that's a good point, yeah.
And he has his wife, but she doesn't have really anything outside the house. That's a problem.
He likes
Yeah,
to work with
right.
his friends.
Right, yeah,
And he is going to the pub, but we don't know how long that can last.
right.
But it definitely, that is good. I'll just as a side note, in the Netherlands, I don't know about today, but a long time ago, they had in their annual disability survey, they had a question, how often do you go to the pub?
Wow.
because it's such a part of the culture,
Right.
and it's an
Yeah.
indicator of how healthy you are
Social you are.
and social you are, right? Because people don't go to the pub by themselves, generally.
Yeah.
So it was it's interesting, isn't it? So,
Social marker. Right. That's really cool.
Huh.
Yeah. Uh-huh.
but what,
Yeah, we kind of hit on all the ones.
those are it. Yeah. So, and then environmental, and I think we've also started talking about a lot of those environmental factors too. So I'm just gonna hand out the thing. We can still talk about these, but I'm gonna hand out the.
You wanna see
The answer?
I'll pull it up.
Oh, yeah, the answer key. But you guys don't.
We should grade ourselves.
It's fine.
Right, so interesting how like, so they put care and concert partner under environment, and I was kind of thinking under personal factors, so yeah.
But that's
So you
why I was
kind of
not
go both, yeah.
As long as whatever approach you take is consistent.
I agree, right,
Yeah,
exactly.
that's definitely what happens if we use this
Right.
research.
Yeah,
As long as
right.
you're consistent.
Right, mm-hmm,
And sometimes, and people are looking at environmental factors because they're trying to see what can we change as a society.
yes.
Right. So if transportation is highly linked, for example, as an environmental factor, access to transportation is highly linked to whether or not the person actually gets out in society, like their participation. If those things are heavily linked, then we want to make sure we do something
Right.
to address that.
Yeah, that was a really
Cut out
interesting point, like
certain
what
things.
order of intervention is
Yeah.
needed, right? So like what you were saying about maybe we can't change the distance to the pub, but we can change his endurance. Or maybe we can, long-term on the population level, as Christine was saying, build more pubs or better transportation or groom the roads more effectively.
Exactly.
Or, you know,
Right.
so
Maybe
different
there's
people
Uber there,
will use the data in different ways.
Yes.
But there's the thing that you can do, and then the thing that's like a population.
Right.
And that's why I think it was excellent to have an interprofessional presentation of this,
Yeah.
because people are using this framework in different ways, and I love
Right,
that.
I do think it would be, really interesting and, physical therapists could be contributing to like a data set to look at, if we were to put these things in and look at, what are the commonalities, like you said, we have this many people that are wheelchair users in Philadelphia, and these individuals in this part of the community are getting to, let's say, go to Eagles games and stuff, but this group is not. Why isn't it? Is it the public transportation?
Right.
Is it not safe for them to leave their house or whatever?
Exactly.
Yeah.
And then on a sort of comparative level, you have this great option to say, okay, well, we have two groups of people with broken hips, and this one is going out and about and this one isn't in the Netherlands versus Philadelphia. Are the roads better? Are the this better? Or is there like a different cultural attitude towards what we do? Is there the houses colder? Or is the,
Right.
Transportation easier.
Or are people just more resilient? Like I was just with our students in Guatemala, and the roads are just not conducive to wheelchair use there at all, right?
Neither in Philadelphia.
Yeah, but they make Philadelphia roads look like, a racetrack. And so, but what's interesting was that it was very, at first, it was really very upsetting to us, my students and I, that this young man who had a gunshot wound, and so had spinal cord injury, he did not have a wheelchair at home. And so we thought, gosh, but then when we were educated to think about, okay, well, in his home, people either physically move him, or things come to him. So he's taken care of, all of his needs are met because of his culture. And then there would really be no benefit to a wheelchair outside the home because the environment isn't useful, right? So you think about who should we give the wheelchairs to? We have this limited number of wheelchairs. And you think, okay, well, it's probably better to give somebody who can use a wheelchair in, like somebody that lives in a facility. There was like a child who lived in a foster home. So she got a wheelchair because she could be pushed all around, right? She could get on the bus and go places. Right. This young man that lived in this rural village, but it was interesting, his activity and participation needs were all being met because his family was modifying their life, something that probably wouldn't necessarily happen in the U.S. in the same way.
Because they were modifying their behavior.
They modified their behavior because it's just their culture.
And I think that's interesting. There's a term called visitability, and it addresses that issue of there's a tendency to think of the individual. We want the individual's home or place that they live to be as accessible as possible. That's our first thing, right? The occupational therapist will actually go in the home. How can we, because you're now using a wheelchair, how do we get around, right? And they're actually, and we're looking at, when those of us study aging, we want to do these assessments of homes for fall prevention. Right. But yet on the other side of this is if we have a situation where that person could have a lot more visits from other people. If no matter what we do inside the home, we also want to address the outside the home and also maybe community centers where people can actually congregate. So even if their home is not perfectly accessible, but if there's a place where people can congregate or where we can make entranceways to other places like churches or community centers as visitable as possible, then seniors or disabled people have a better chance of being visited as well as visiting others. So anyways, it just turns it around. It's not that one way is the right way, it's just a matter of having that as another tool.
Right, but you're gonna use community resources, like let's say.
Yeah, you only have
Medicaid,
limited.
Right, we should maybe be using it for like the greater good, which would be more people at a visitable.
And that's,
place.
yeah,
Well, it just raises the point, what is the overall goal here? The overall goal here is to, however you want to put it, enhance people's daily living and life experience. And we imagine the way to do that is to give them as much independence, but that's not always true, because independence is something you need if you don't have people to depend on, or you don't want to depend on them. Let's say that's fine for you and that piece is in place.
And
Then there's other things we need to do.
That's right. And also,
what I'm thinking of is, maybe the family adapts their lives around the individual, but the individual is feeling smothered and like they don't have a future.
Right.
So they can't, improve and such.
So that leads me to my question about sustainability. Like when you guys do these assessments, do you look at it within a certain time window? Do you look at it within a certain, like how sustainable it is past 6 months? Or I just don't know.
Yes. So I think we will look at like short-term goals and then like a long-term objective. And there's really a move in physical therapy and rehab to look at spreading visits out. And so there is definitely a trend for, let's say Bob in the US. Let's say Bob had Medicare and he could benefit from using a Medicare B. It's an outpatient visit, but many companies are doing Medicare B outpatient in the home. So that's the ideal. Instead of having Bob go to NovaCare down the street near the bar, right? He goes, NovaCare therapists come to him, or a different company comes to him, and they work in the home. And if they are skilled clinicians in looking at this person, they can spread their visits out. So initially they work for like a month to build his endurance up. Right. Then they decrease it to every 2 weeks and then every month, and then they may stop the care, knowing that most likely they'll need to come back in when something else happens.
Right, because also here, as you stated, there's also that mental component too.
Yes.
So as you can sort of feel the line going, as his mental capabilities go down, his wife is going to hit a point.
Well, and so so the other thing that sometimes what will happen, like for a physical therapist, they would look in and say maybe it would be also to have OT, but could we get a office on aging person to come in and talk with the wife about resources? We can connect them with resources. Maybe there's a senior center that he could go to once a week so that she could get her hair done, that kind of stuff. So physical therapists often, and I would say occupational therapists, do often kind of wear other hats, but the ideal thing would be to have a team.
Yeah.
And sometimes the team is consistent. Let's say if you're working with the MS Society and you were the PT going in there, there's more resources. But if you were working physician referred you, then you often need to sort of find your own team.
Right.
Yeah.
Thank you so much, everybody.
Yeah, this was really